I went and met with a young woman, Paula, I will never forget her, at Audubon. And she's my age, and she had a 5-year-old little boy. And she had been battling some cancer. And went and met with her family and had that end-of-life discussion with her and helped to try and paint a picture of what it would look like to be at home with hospice care. And that moment with her I will never forget, and she has always touched me. And having that end-of-life conversation with her helped me realize some things that I need to not take for granted.
One of my first patients in the cardiovascular unit, he was a full code. He was dependent on a BiPAP 90% of the day, and he realized that he did not want to live like that. And I talked with him based upon him engaging with me about what his other options were. And once he realized that he did not have to stay on that BiPAP all the time, that he could use medications, be comfortable, and allow the natural process to play out, he did go with that. He allowed the natural death within the time frame and within the context that he chose.
One personal experience I did have that related to an end-of-life conversation relates to the fact that I didn't have that conversation. My mother passed away a couple of years ago, and during the last 7 or 8 years of her life, she suffered from Alzheimer's. Unfortunately, by the time we were aware of how serious the illness was and how it was going to progress, she was at the point where we really couldn't have a conversation with her. Her mental capacities were such that we just couldn't carry on that conversation with her.
I use a lot of stories when I try to open the door to end-of-life conversations. So I was using a story with this gentleman, and it made him cry. And he said, you know, I'm ready to go. I don't want to live like this anymore. It's not any fun. And his daughter was totally taken by surprise. She was so sure that he was having fun still and enjoying his life that it made her cry, and it opened her up to having that conversation with her father.
I actually just recently had a personal conversation with my parents, and what prompted me to have that conversation is that my uncle is suffering from some serious illnesses, and my cousin is the primary caregiver. Because she never had that conversation, I believe that both of their qualities of life are not great. So I actually used that as a starting point with my conversation with my parents, and I brought up my uncle, and I said, hey, you know, what do you think about Uncle Chet? How do you think he's dealing with his illness? And that really opened up a very active dialogue with my parents, and I was able to use that.
A good conversation to me with a patient and family is one that when I've provided them an explanation of services, you can see them take a breath. They're like, the sense of, wow, there really is help out there for me.
When you can gain trust very quickly with a family and a patient, you can assess very quickly what it is they need, what it is their main focus. And when they feel heard, when they feel like their needs are validated, and the end result is that you can help them with a service they greatly need and they realize they need it.
The person feels that this is a safe environment and they can express whatever feelings they have, freely express whatever thoughts they have. It's also a good conversation if they feel empowered after the end of the conversation, if they feel like they now have the knowledge that they need to be able to make an informed decision, and that they know that this is something that they have some input and control over, that they don't just have to go along with whatever comes their way.
It starts with making good eye contact, choosing a time that's appropriate, in which there's not a lot of distractions, in which you can actually start a conversation and allow equally active listening skills on both sides. A good conversation is one that you express how much you care for the person and how much you want to honor their wishes.
A bad conversation with a patient especially is one where they are closed off. They are sitting with their hands crossed and really have put up a barrier because of all of the misconceptions that they have heard about hospice care. So my job with that patient is to break down that barrier and to clear up those miscommunications so they become a little more open to the information that I'm providing to them.
When the families don't feel like you've heard them, when they feel like you have been rushed, when their needs are not met, when they feel like you're just not getting it. However, a bad conversation can very quickly be turned around if you stop, read their body language, and meet the needs that they're presenting to you.
The person feels like his feelings or thoughts were not heard, were not understood, were not appreciated, that they were being judged. Bad conversation is one that is rushed, where the person listening is insensitive, does not recognize or affirm the feelings or the thoughts that the person has who's discussing the end-of-life needs.
It's one that almost feels like an afterthought, like, oh, by the way, I need to talk to you about how you want your final days to be. That is not the way to start a good conversation. A bad conversation is one in which you haven't given enough time or thought. A bad conversation is one in which you aren't listening, that you put words in the other person's mouth, that you actually try to assert what you want rather than the person's wishes.
I always commend them on making that step, on getting the education about end-of-life care. You can't make the best decision for your family and for your loved one without having the information available to you.
Hospice care is never giving up. It is a change of focus. It is a shift of focus, realizing there are limitations based upon disease progression. And based upon those limitations, we can focus on what the family and the patient do want.
Tell me what you know. Help me understand what you are saying. Do I hear you saying? How do you feel about that? What do you think about that? Those feelings, those thoughts are normal for someone in your situation. Those are some of the things that I usually use during the course of the conversation to try to create a safe environment where the person feels free to express whatever's going on in their mind and in their heart.
I always say, I'm here because I love you, because I care about you, and because I want to honor what's important to you.
I never say dying. I refer to end-of-life care as a journey. And I never say to a patient and or a family that it's going to be okay.
I do say that it's important for us to figure out what the priorities are here, but I never focus on the death and dying or the negative aspects unless those are things that I can specifically help with and improve for them.
Statements like, you shouldn't feel that way, or you shouldn't think that, that's very judgmental and will shut down the conversation. Also to say, I know exactly how you feel, will shut down the conversation, because if you know exactly how they feel, then there's no need for them to speak any further about those feelings.
I would never say, this is what I think you need to do. I would never say, it's going to be okay. I would never say, well, let's not worry about that right now. We can come back to it. Because it is important. And if somebody is expressing feelings of anxiety, feelings of doubt, it's important to them to hear that.